Hello and welcome once again to the next webinar in my series of at-home functional medicine specialty testing. Today we are going to be discussing another specialty functional medicine test that can be done at home. Oftentimes this test is undertaken at a laboratory setting simply because it does entail venipuncture, that is to say drawing blood from a vein, typically in the arm, as several milliliters of blood are usually required in order to run this full panel of tests. That being said, it is possible to arrange to have a mobile phlebotomist come to your home to draw this blood to have this testing performed if you are feeling as though going to a lab is not really the right choice for you under the circumstances of the current COVID-19 pandemic. We'll get a little bit more into all of the specifics around the lab here in just a minute. First, the typical financial disclosure, nothing new here. And also just wanted to provide the latest update on COVID-19 statistics. Again, this has reference to confirmed cases, which we talked about a couple of weeks ago. Suspected cases really, there's a lot of good scientific evidence to suggest that suspected cases really are quite a bit higher, a couple of orders of magnitude really, than what has actually been confirmed. That being said, confirmed cases still going up, and it's good to see that the confirmed fatality rate has actually started to decline a bit. We're now down to about 6.5%. So that is a little bit of encouraging news in the midst of everything else that we're facing. Also, interesting story. The president said that he is taking hydroxychloroquine. That has prompted a bit of a response from many healthcare practitioners. There's some interesting quotes from the president highlighted from this article in the New York Times from Monday. And seeing that this is really making a lot of public headlines, I thought it would be good to go through what some of the science actually shows about this particular medication, hydroxychloroquine. There were, in fact, two studies that were both just published last week in BMJ, formerly known as the British Medical Journal. So very recent studies. This first one that we'll talk about was a French study, 181 patients, 18 to 80 years old. They all tested positive for SARS-CoV-2, the virus responsible for COVID-19. Each of these individuals with pneumonia on oxygen, but not in the ICU where they had been admitted. There were basically two groups. There was this treatment group and a control group. Now, the treatment group was given hydroxychloroquine at a dosage of 600 milligrams daily. This was, for most of these individuals, started within 48 hours of their admission to the hospital. There were a handful that for whom it took a little bit longer to actually get this medication started. The control group just received essentially standard care. The outcome measures used to evaluate the efficacy of this medication were several. The primary was essentially whether or not these individuals needed to be transferred to the ICU by day 21 of their hospital admission. Some of the secondary measures that were looked at were whether or not the individuals survived, either with or without acute respiratory distress syndrome, which is really this hallmark of hospitalized patients dealing with COVID-19, often enough on ventilator support. Additional secondary measures, how quickly or whether or not these individuals were able to wean off of that supplemental oxygen, and whether or not they were able to be discharged from the hospital. The results showed that the treatment group had basically a 76% rate of not being transferred to the ICU, as opposed to the control group, which had a 75% rate. Secondary measures in terms of overall survival, there was 89% survival within the treatment group versus 91% in the control group. Survival without acute respiratory distress syndrome, 69% in the treatment group, 74% in the control group. And weaning off of supplemental oxygen, 82% in the treatment group versus 76% in the control group. The conclusion that the authors publish were basically that the results of the study do not support hydroxychloroquine's use in patients admitted to hospital with COVID-19 who require oxygen. Now, that's really a very particular way of phrasing that conclusion. And, I think it does allow for a little bit broader of an extrapolation that really this isn't necessarily, based on what these investigators saw, beneficial to the overall course or progression of this disease state. There was an additional study in the same journal issue. This was a group of Chinese clinicians and researchers. They had 150 patients. They were all 18 years of age or older. They each had confirmed COVID-19, and they were given basically a loading dose of hydroxychloroquine in the treatment group at 1,200 milligrams per day for the first 3 days. That was then decreased to 800 milligrams per day. Now, there was basically a consideration of whether or not this disease was considered mild versus moderate. And if it was mild, then they were given this treatment if they were in the treatment group for 2 weeks. And if it was considered moderate, then they were given the treatment for 3 weeks. Now, the control group was basically given standard care as well. And then the primary measures looked at in assessing the outcome were considered to be at the outset negative conversion of SARS-CoV-2 in 28 days. Now, that's a very wordy way of basically saying these individuals had all tested positive for the virus. Negative conversion was looking for a subsequent finding of a negative testing for the virus, not the antibodies, but actually the virus present in testing of these individuals. And they wanted to find that on 2 separate occasions with at least 24 hours in between those 2 assessments, and no further subsequent positive testing after those 2 negative tests. The other primary outcome measure that was being considered was no progression to severe COVID-19, because again, these individuals in the study were either deemed to have mild or moderate COVID-19 at the outset. There were some secondary measures as well, but there was a little bit of unexpectedness with this study, and as it turned out, they really had to just kind of stop by assessing only the first of the primary measures. And there was even some conversion. People who had originally been in the treatment group had to switch to the control group and vice versa. So there was a little bit of a change in the numbers. Nothing huge overall, but it seemed like they found results which were basically that there was negative conversion at 28 days in 76% of the treatment group versus 70% of the control group. And that was really enough for them to say, given all of the other unexpected specifics that yielded further complexity in the study, that essentially there wasn't a benefit to this. Now, they did also find some additional adverse events far more likely to occur in the treatment group than in the control group. The most common of these adverse events was diarrhea. That happened to 1/3 of the treatment patients who experienced one of these adverse events. There were some serious adverse events as well in the treatment group, and that basically entailed progression of the disease to the severe status, as well as the development of upper respiratory infections. All told, the study authors came up with a very wordy conclusion, which was that administration of hydroxychloroquine did not result in a significantly higher probability of negative conversion than standard of care alone. Essentially, it didn't do anything in patients admitted to hospital with mainly persistent mild to moderate COVID-19. Adverse events were higher in hydroxychloroquine recipients than in non-recipients. So again, not strong evidence to support the use of this drug so far. I suppose it's possible another study in the future may turn up a differing opinion, different evidence, but thus far, based on these two studies, again, just from last week, not really a ringing endorsement of the use of this medication. Okay, moving on to the topic at hand, intracellular micronutrient testing. Before we get into that, let's just talk very about how we take in nutrients. Largely speaking, there are 6 steps. We got to chew up our food, we have to swallow it, we have to mechanically and chemically digest these nutrients that we're taking in. We have to then absorb them from the digestive tract and take them into the bloodstream to be able to be distributed throughout the body. And then any waste that are left over need to be eliminated. Largely, we are going to be talking about these 3 different areas in consideration of this testing. So the actual processes of mechanically and chemically digesting these foods, nutrients that we take in. You know, by a similar measure, we could even consider nutritional supplements. Usually we aren't chewing those up or, you know, swallowing pills or possibly a liquid. But the same idea holds. It's still going in through the digestive tract. But in particular, we are going to pay close attention to this process of absorption. And that you will see is going to figure prominently in our considerations. Now, there are multiple potential pitfalls to this whole process of nutrient absorption. At the outset, really just this idea of poor digestion, which really does apply to everything that we could take in. Each of the 3 macronutrients, things like proteins, fats, and carbohydrates, but also vitamins and minerals as well. That could be because we don't chew our food adequately. It could be because we don't have an adequate production of saliva. It could be because we have a deficiency in the production of hydrochloric acid in the stomach, or a deficiency in the production of digestive enzymes, most of which is occurring in the pancreas. Could also be because of a deficiency in the production or release of bile salts. And that really involves the liver and the gallbladder. Now that's going to have more particular relevance to the digestion and absorption of fats, but we'll talk about that here in a second. Also, we spent a fair bit of time discussing this concept several weeks ago when we discussed comprehensive stool analysis testing. If there is a state of hyperpermeability at the layer of the intestinal epithelium, that will often result in excess levels of inflammation, both within the gut and in this intestinal area, which is so critical to the absorption of these nutrients. And that can certainly interfere with this process of taking these nutrients from the digestive tract and getting them into the bloodstream. And then one other specialty topic, this idea of intrinsic factor, which is really a critical component that the stomach produces and which is needed in order to be able to absorb vitamin B12 from the digestive tract and get it into the bloodstream. But let's talk about some of these first items up top first. So we can see here a rough drawing, a rough representation of this middle component of the digestive tract. And we mentioned the production of stomach acid, hydrochloric acid, which is happening here in the stomach. And if that is insufficient for one reason or another, often enough, this is because of the usage of stomach acid reducing medications. That can render the chemical digestion that needs to happen in the stomach at a disadvantage. We can also think about the production of digestive enzymes, which is occurring here in the pancreas. And if that is problematic for one reason or another, that can also get in the way of adequate chemical digestion of the nutrients that we take in. Bile salts are produced in the liver and then they are stored in the gallbladder until such time as food is taken in, at which point they're dumped all at once by contraction of the gallbladder and conveyed to the start of the small intestine by way of the common bile duct. And that needs to go through this particular opening here in the duodenum, the first part of the small intestine. And if there are any issues with any of those different processes, then that can be problematic for the digestion and absorption of fats. Now, as I said a moment ago, hyperpermeability at the intestinal epithelium, that can be a problem as well. And again, we did discuss that several weeks ago. If you missed that webinar, it is available on my website. You can go check that out, pvosteo.com. Look in the audio video section and you'll see a link to that webinar there. But food basically is making its way through the intestine from the stomach in what we refer to as the lumen. And as it proceeds along through the small intestine, it is going to come into contact with this intestinal epithelial layer. And really the point of interface for crossing over, for absorption of these nutrients is at this microvilli brush border, which is blown up here in the top right, that are sort of a microcosm, tiny projections off of these otherwise larger, more macroscopic projections of villi. Now, these nutrients that we've taken in are going to be absorbed in different ways. Amino acids, which are the broken down byproduct of proteins, and the broken down simple sugars of carbohydrates are going to cross over via this intestinal epithelial interface and be taken up by the bloodstream in terms of these blood capillaries. Fats, on the other hand, are going to be shepherded over and are going to be absorbed into this anatomic structure known as a lacteal, which is an offshoot of the lymphatic system, and they will be transported back to the central circulatory system, where they will then join the bloodstream. Now, if there is hyperpermeability of this intestinal epithelial layer, as shown here on the right side of the screen, there's going to be all kinds of inflammation, immune system activation, breakdown of this interface that will get in the way of this absorptive process. So again, that's something that we can really better assess by way of the comprehensive stool analysis. Fascinating conversation, topic of discussion. So check that webinar out if you haven't seen it. And then more specifically in terms of B12 absorption, this is going to involve both the stomach and the ileum. The ileum is depicted in the top left. It's basically the latter portion of the small intestine. So essentially what happens is that the stomach is producing this intrinsic factor in the cells that line the stomach. And as B12 is coming into the stomach in either supplement form or the foods that we have eaten, it is connecting with this intrinsic factor, which essentially chaperones the B12 through the first portions of the small intestine to protect it, keep it safe, and then enables it to cross over at that intestinal epithelial interface to enter really these epithelial cells. At that point, the intrinsic factor sort of releases the B12, and then the B12 is able to cross over the backside of that single cell layer lining of the intestine to join into the bloodstream where it's then transported by a different protein. So this whole system needs to be functional and working well in order for us to have adequate levels of B12. And again, if we either are altering the standard makeup of the stomach, typically by way of proton pump inhibitors, but there's also certain autoimmune processes that can attack these parietal cells in the stomach that can lead to difficulties with absorbing and maintaining adequate levels of B12. Moreover, if there have been any surgical interventions, which might have been definitely needed, indicated, to remove portions of the small intestine, that limits or possibly even removes altogether this point of absorption for B12 in the small intestine. Now, let's assume everything has worked well, we're eating a balanced diet, we're chewing our foods, we're absorbing them well. Then they enter into the bloodstream. Now, the bloodstream, most people probably think of blood as, oh, it's this red liquid. If I cut myself, I see it. And certainly that's true, but there's a lot more going on. That redness, of course, comes from the red blood cells themselves, but there are also white blood cells, there are also platelets, there's also plasma. A lot of times we may use the term serum. The distinction between plasma and serum is certainly real, but it's not particularly important for this conversation. So if you hear me say serum, then that's really what I'm referring to, this plasma, basically this fluid, largely water-based component of the bloodstream, within which these nutrients are essentially dissolved, and that essentially conveys them throughout the body to be distributed to all of the cells of the body. Now, there's a pretty significant distinction between red blood cells and white blood cells, which we're going to be talking about here in a second. But first, let's just cover this idea of body cells themselves and what makes them up, and factors that we need to consider as well on the actual final delivery of these nutrients throughout the body. The key idea here is that there is a barrier that separates an individual body cell from the rest of the body, and it is largely comprised of this phospholipid bilayer, which makes up the cell membrane. And the cell membrane, you can see, really does create a distinct separation between the outside and the inside of the cell. Now, in certain cases, if a molecule or a substance is small enough, it can cross over that cell membrane barrier without any difficulty at all. It just simply diffuses across, which is to say, based on concentrations, these molecules will just sort of move around randomly to distribute themselves as evenly as possible throughout the spaces that are available to them. And if they're small enough and nimble enough, essentially, this cell membrane does not really serve as a barrier to their entry to the cell. Other molecules are somewhat larger. They do essentially bump up against this cell membrane, in a sense, as a barrier, and they need help getting across to gain entrance into the cell, which is really where we need our nutrients. We need our nutrients inside the cell. That's where they are utilized. The cell is the basic unit of the expression of life, and these nutrients, which support life, are made use of on the interior of the cell by and large. So in certain cases, there is a process known as facilitated diffusion, which is it's an energy, it doesn't require energy to effect, and essentially it is a facilitated way of allowing those normal forces of even distribution throughout an available volume of space to take place. It's basically a protein that's embedded within this cell membrane that allows for a larger opening for these larger molecules. Now, in other cases, the body wants to concentrate different substances against that natural tendency to just evenly spread out everywhere. And in such cases, it essentially needs to have a pump of sorts that is, in effect, sort of pushing water uphill, so to speak. Except in this case, it's a particular molecule. It may be larger, it may be smaller, but it is being concentrated against that natural tendency of diffusion. And that does require energy. And that is essentially the transformation of ATP into ADP. So, that's a little bit deeper of a conversation, but suffice it to say that the body has to work to make primary active transport happen. If any of these processes are challenged, or if there is a structural abnormality to the cell membrane itself, this process, whichever route is utilized between these three available options, can be challenged, and we can end up with reduced levels of intracellular nutrients. And that's an important concept to bear in mind as we continue this conversation. Now, let's talk about the different types of testing that are available. In terms of the intracellular micronutrient testing, there are a couple of different providers. I have tended to use Spectracell mostly. Vibrant America does also offer an intracellular assessment. Generally speaking, the pricing has some degree of variability to it. And of course, this boils down to what type of insurance you have, is there a medical necessity, and where are you going to be having the blood drawn to have this testing performed. If you have excellent insurance and there's a medical necessity and you go to the lab, you're going to be looking at the lower end of the scale. If you are going to be paying out of pocket because there isn't a medical necessity, you just have a certain amount of curiosity to know what your levels are looking like, and you want to avail yourself of the mobile phlebotomist services, then you're going to be looking at the higher end of that spectrum. Of note, Spectracell offers simply the intracellular testing alone, whereas Vibrant America offers a combination panel that gives the intracellular testing as well as the serum testing. So that allows for a certain comparison of levels within cells versus those in the bloodstream. And if there are significant differences between those two levels, typically that is lower intracellular levels relative to higher serum-based levels, that is indicative of a potential challenge with that cell membrane barrier. And if we run that test and we have that finding, then we can start to think about what types of treatment interventions might be indicated to bring about improvement to the cell membrane itself as essentially being a hindrance to getting adequate amounts of these different nutrients inside the cell where they're truly needed. Now, this testing is performed, it's really a very creative mechanism by which these levels are assessed by way of a whole blood draw. And we didn't talk about it yet, but we will here in just a second. Red blood cells themselves are not what are studied in this assessment. And that's because red blood cells are quite a bit different than body cells by and large. So what happens then is that whole blood is drawn, and lymphocytes, which are a certain type of white blood cell, which are far more representative of body cells, are then grown in a culture containing everything that they would need in terms of nutrients to be able to survive and thrive. This creates a baseline marker of growth, which is used for comparison for all of the other studies within this test panel that are undertaken. Then different subsets of these lymphocytes are grown in various cultures that each contain everything that is needed for growth except for one of these nutrients that is being assessed. Now, this allows for a key investigation into what levels of that nutrient are inherently already present within that cell from the donor, from the patient who's looking to get these results. The reference ranges that are utilized are basically tabulated from all of the thousands of different other studies that have been performed. Now, this is with specific reference to SpectraCell. This is their methodology, and they have undertaken thousands and thousands of these tests. So they've really compiled a pretty extensive statistical model for what would be, normal, what would be, an outlier on the high end and the low end. And from that, they're able to come up with essentially these reference ranges. Now, I mentioned a minute ago the difference between red blood cells and white blood cells. Really, the key difference here is this idea of size and nucleus. And really, red blood cells are quite a bit smaller, and they don't have a nucleus when they are mature and they're undertaking their typical and sort of well-known activity of carrying oxygen throughout the body to provide to all of the body cells. And it's for this reason that we really can't use them in this capacity in the way that this test has been designed, and why we have to use the lymphocytes, one of these white blood cells, to assess. But again, it's really a very creative solution to this problem, because otherwise we'd be talking about needing to undertake a biopsy of some sort of, a very minor sort of excision of some sort of tissue. And with a simple blood draw that, most of us are used to having performed at one time or another in our lives, this that need is really sort of avoided, which is great. Now, these are going to be some representations of the sample tests that SpectraCell has on their website, just to provide a sense of what the test report looks like. Now, this is essentially the executive summary, first page, which provides at the top all of the frank deficiencies of various nutrients. Just below that, some of the borderline deficiencies, and below that even an overview of some of their more global assessments for this sample individual. Throughout their testing, you will see this sort of informational design by which they can denote what is considered a normal result. That would be something that would be in the green bar and denoted with a white circle. We don't see any on this page yet. An average, or as I've called it earlier, borderline, which would be in the yellow section or bar and denoted with a black circle, and then the frankly deficient area, which is in the gray bar and denoted by the red circle. Now, these algorithmic summaries at the bottom, Spectrox Immune Index and total immune function by age, we're going to see a little bit later. Not so much the total immune function by age. That is a useful assessment, again, based on all of the thousands of other studies that they have run. Ideally, we'd like to be somewhere much closer to that green line, which does naturally decline with advancing age. That's just a normal byproduct of aging. This individual is woefully deficient, unfortunately, with respect to total immune function, according to this depiction. So the SpectraCell report is broken up into different sections. The B complex vitamins, as they call here, basically are a specific reading for each of the B vitamins. And we see a couple of frank deficiencies here, B1 and B3, as well as a borderline deficiency, B2, and then essentially everything else is considered normal. Now, when I work with patients to interpret test results, these intracellular micronutrient test results, I really do like to see as an ideal or an optimal finding that the specific nutrient comes back right in the middle of the green bar. We don't want to be borderline or almost borderline at the very low end of the green section, nor do we want to be at the very top of the green section. There are issues that can result from having too much of certain vitamins. A lot of B vitamins in particular, are water soluble, so it's very difficult to become overburdened by them in any sort of clinically significant way. But that does not hold with respect to other vitamins. So again, I really like to see my patients' test results as much as possible come back right in the middle portion of the green section on these graphs, and use these results to put together a specifically tailored remediation for my patients based on what their intracellular levels are looking like. Now, we also get additional vitamins. These would be vitamins A, D3, K2. Those are all fat soluble. So those are ones that potentially could be problematic if levels were too high, for example, as well as some important minerals, elements, manganese, calcium, zinc, copper, magnesium, each with their own particular clinical relevance, each which may point to an underlying cause for an as yet unidentified reason that a patient might be struggling with a particular complaint. So sometimes we didn't necessarily know that, oh, vitamin A is actually borderline low. That could have something to do with why you are having this low grade but persistent skin complaint or immune system deficiency. And again, each of these has their own particular clinical significance. And the value of this test is that we get such a broad and specifically relevant screen in the case of, we don't really quite know what's going on for you, why you're having these complaints, but let's run this test and let's see what it shows. In this section, we get some insight into various amino acids and metabolites. Now, these amino acids are what we would call conditionally essential. That is to say, they're not essential amino acids, meaning we can only get them by way of foods or dietary inputs, and they're not, readily available amino acids that the body can convert other amino acids from to be able to produce. They're conditionally essential, meaning if the body doesn't have certain key ingredients, it won't be able to make enough serine or glutamine or asparagine. So these have they were chosen intentionally, as opposed to doing a full panel of all amino acids, to specifically target how the body's biochemistry is functioning just below the surface. And then in terms of antioxidants, how is the body managing its overall oxidative load? That really speaks very significantly to the potential for the development of chronic disease over time. In particular with this individual, again, this is just a made-up person, their glutathione is very, very low. Glutathione is the master antioxidant in the body, and if that were found to be low, to my mind, that would be particularly concerning, and we would want to do something about that in a very specific, targeted, and sincere fashion without delay. There are others here as well. You'll see vitamin C. That wasn't included in the earlier vitamin section because it really does have such a strong antioxidant functionality to it, as well as vitamin E, for example. Now, we saw these earlier on the executive summary, the Spectrox and Immunidex. So Spectrox is an algorithm that's looking at overall antioxidant function. This is a unique feature of the SpectraCell intracellular micronutrient test, and it's really a combination of glutathione, which I just mentioned, vitamin C, and alpha lipoic acid. So they infer from the specific levels for each of these three markers an overall sense of antioxidant function and arrive with sort of a global score. And again, we'd really ideally like this to be solidly in that green component of the bar. The Immunidex is a similar idea, but with respect to immune function. And this is based on the scores for vitamin A, vitamin D, and zinc, each of which are very important for the immune system's functioning. So we get this report, we look at these results, and we try to make a clinical choice around how to proceed, how to respond to the results. And often enough, when there is a deficiency on this test panel, it has to do with one or several of these various factors. The patient isn't getting adequate intake of these various nutrients. Maybe that's because they're eating a less than optimal diet. Maybe that's because they're doing the best that they can, but there's some sort of issue with their food choices, and so they would really benefit from some nutritional supplements to just help fill in the gaps around the edges. Maybe it has to do with their digestive processes or how well they're absorbing the nutrients. They're eating everything they should. They're taking nutritional supplements, and they're just, for whatever reason, aren't digesting or absorbing them well. Or maybe it has to do with the actual cell membranes themselves. Now, I would say as well, within this whole concept is the idea of, no, I'm taking vitamins, I'm taking supplements. If those vitamins, if those supplements aren't of a sufficiently high quality, something that I often refer to as pharmaceutical grade, then that can be the problem. So really getting this baseline assessment inside your cells, this is the reality, and then working backwards from there to uncover the reason why, and ultimately achieving clinical improvement as a result of that inquiry and treatment process. So based on what the results would be for any given individual, there would typically be some sort of dietary or pharmaceutical grade supplement recommendation that was customized to those particular deficiencies. If there were issues with digestion or absorption or that intestinal epithelial barrier, we would also want to consider that. And similarly, if there's something going on at the cell membrane level, we'd want to correct for that as well. We allow a certain period of time, 6 months, 9 months, 12 months, with consistent effort along the lines of the treatment plan that we initiated. And then we would recheck to make sure that we were on the right track. And that's really ultimately the goal. We want to get these nutrients in the appropriate amount to where they need to be to do the job that they're there to do, so that the individual can express health as optimally and fully as possible. That, in a nutshell, is really the value of the intracellular micronutrient test. Now, here we are in 2020 in the midst of the COVID-19 pandemic. I have had to adjust my practice reality a little bit. As a result, I'm offering complimentary 15-minute consultations to anyone, whether a patient or not, to discuss the use of pharmaceutical grade supplements. And certainly, if you wanted to go a little bit deeper than that, you could. I am working with new patients in a functional medicine capacity, and you could, again, do the 15-minute complimentary consult, or we could do a 30-minute consultation, which would be a paid consultation as the first half of my overall initial visit structure, which is typically 1 hour when there isn't a viral pandemic raging. And typically that's done in person, all 1 hour, all at the same time. But due to our reality, this is the alternative that I've come up with. Anyone who's already established with me in my practice would certainly be welcome to take advantage of the ongoing use of a teleconference for whatever wants to happen next. Functional medicine test, development of new symptoms, complaints, just a routine follow-up because you're looking for that refinement of wherever you are. Now, the complimentary 15-minute consult, for anyone who is new to my practice, Pioneer Valley Osteopathy, this does allow for the establishment of an account with FullScript, which is the online supplement dispensary that I use with all of my patients that carries only pharmaceutical grade supplements. And I also provide a 10% lifetime discount to everything that FullScript carries to anyone who takes advantage of this complimentary consult. More than happy to talk about what supplements you may be taking, might be interested in taking, whether or not those would be recommended or indicated, And certainly we could consider the possibility of specific functional medicine testing with the actual coming on as a legitimate patient and not just availing yourself of the complimentary consult. Pharmaceutical grade supplements, I've mentioned this already. The reason that I value them so strongly is because of the guarantee of a standardized dose. You know exactly what your body will be receiving without any additional ingredients that will detract from the efficacy of those supplements. And each of these products has been subjected to quite rigorous quality control. So we can count on what's written on the label as being what is going into our body. It's also very important, and this is really why I use Fullscript, in addition to the fact that I just don't want to spend my time managing inventory here in the office. And that's actually worked out better in this current reality of COVID-19. These supplements are kept and maintained under ideal storage conditions that are turned over with a high enough frequency that the expiration date doesn't really need to be a consideration. And they are shipped to you under conditions that maintain their integrity. For example, probiotics often enough need to be kept in refrigerated conditions, or the viability of the overall bacterial population that they contain tends to decrease. And then lastly, if there is an issue for whatever reason with the actual product, knowing that there is very robust customer service behind you in your purchase is very reassuring to my mind. Once we get through this COVID-19 pandemic, I will be accepting new and existing functional medicine consultation appointments here in the office again. I'm already starting to work with my osteopathic patients once again. We're needing to take additional sanitation measures, precautions. We're gloving up and masking up. So I'm not able to see as many over the course of the day. If this is of interest to you, please reach out to us here in the office and we can discuss all of these considerations and look at schedules to see when it might make sense to bring you in for an osteopathic treatment. Anyone who's already established, of course, can continue to make use of the telemedicine consultation route even after COVID-19 has dissipated. And I will continue to offer the complimentary supplement consultations as well, the 15-minute consultations, even after COVID-19 has gone on. Next week, I'm looking forward to discussing salivary and urinary hormone testing. This is a type of testing, the salivary, which gives us a sense of current levels of various hormones, reproductive hormones, stress hormones, melatonin, which gives insight into quality of sleep. That is very useful for getting to the root cause of certain complaints, but it's also a necessary prerequisite for making use of bioidentical hormone replacement therapy. Now, on the urinary side, this is really more looking at the metabolites of hormones, how your body is processing these hormones, and what that speaks to in terms of the potential for developing health problems down the line if less than ideal detoxification pathways are being used in the body. Each of these can be done separately, they can be done together. I'm really going to be going through a lot more of those specifics next week. It should be a really interesting webinar, and I hope you will join us. So once again, let me just say thank you. I really appreciate your kind attention. If you have any questions, any concerns, you need something else that I didn't specifically address, please get in touch. You can call. If you're already a patient, you can message through the portal. You can certainly email me if that works better for you. These are the hours that we are here, and the fastest and most direct way to get us is, of course, to call, but make use of whatever method works best for you. That being said, I am going to say thank you one last time and wish you well. Stay safe, stay healthy out there, and until next time. Bye-bye.